Hello, my name's Alex Wickham. I'm a consultant anaesthetist at St Mary's Hospital in Paddington, and I'm going to talk to you about major hemorrhage. Thank you very much for asking me to talk for a second time at the British-Ukrainian Symposium. I am a consultant anaesthetist, as I mentioned, and my routine daily work involves major trauma, vascular surgery, upper GI cancer and bariatric work, as well as obstetrics. So I manage hemorrhage on a regular basis, and I supervise trauma projects and things related to this, and have authored a chapter about trauma for the Oxford Handbook, including some elements of transfusion. Major hemorrhage, as you know, is a leading cause of morbidity and mortality, and it requires a coordinated team response with early recognition and rapid access to surgery, as well as a sort of protocolized response. It's typically accompanied by volume loss, hemodilution, acidosis, becoming cold, and coagulopathy. And these are the things that we seek to address as a result, to optimize the management. There are a variety of different causes of major hemorrhage, typically trauma, particularly in younger people, surgery, especially vascular obstetric surgery, but also any kind of surgery can be associated with major blood loss, and sometimes it can be quite insidious. Other times it's more overt and sudden. It can result as a complication of childbirth or gastrointestinal bleeding. Ruptured aneurysms is a classic one, the one that we often think of, but it can also result from medical causes such as anticoagulant overdoses or profound coagulopathies. And there are a variety of definitions out there. Typically, it's defined by time and volume, but none of them are particularly helpful for anaesthetists who are in the thick of it, managing it at the coalface. So, losing one blood volume over 24 hours is a useful definition, perhaps for research, but when you're there actively managing it, you can see the blood loss in front of you, and you can tell what a major hemorrhage is. There are other things which seek to define it over a shorter time period, say 50% of the total blood volume within 3 hours, or that requiring greater than 10 units of blood, or that leading to hemodynamic instability. I prefer, and for PPH, there's 500 mils within 24 hours of delivery. From a practical perspective, for an anaesthetist, it's where the blood loss is around about 50 to 150 mils per minute, and you can see it live in the operating theatre, in the sucker, or spilling over the side of the drapes. So that's sort of a more practical definition for when you're watching the bleeding in real time. Recognizing it comes with the classic signs and symptoms: hypertension, tachycardia, the pale, clammy skin. In people who are awake and not necessarily under surgery, there's the reduced urine output and altered mental status, and these things have been classified by the American College of Surgeons into the various stages of shock, which gives you broad brushstroke ideas, but isn't particularly accurate for blood loss, because these things may happen. Some of the sort of signs, so blood pressure, respiratory rate, urine output, may happen at different stages depending on the on the patient. In theatre, there are other elements that you can identify. There's the amount of blood that's in the sucker, whether the surgeons have become very quiet or asking for the lights to be adjusted, or they've changed their conversation from happy tales of the weekend to more focusing on the blood loss. And you can see here there's a suction bucket with about 1 litre in it, as well as some in the cell salvage, as well as some down by the surgeon's foot. What should we do when somebody's bleeding? The first thing, once you've recognised it, if you haven't already got vascular access, is to get large bore vascular access, ideally 2 14 to 16 gauge cannulae in a large peripheral vein. If you can get large bore central access, so much the better. If you're not in a theatre environment, we shouldn't be delaying transfers to the quick line. We should get them to the definitive place and do things all at once. And you can consider intraosseous access if necessary. Other things to do in the early stages are to get blood to the lab, 2 group and saves, to cross-match and a full blood count so you know your starting point. Point of care testing, so arterial blood gas or venous blood gas, gives you critical, useful information, will provide a baseline to which you can target your therapy, as well as viscoelastic assays, so TEG or ROTEM. You can see a TEG at the bottom of the screen there, which can give you guidance on the clotting status of the patient and which products to use. And it's also important to remember to call for help, because managing a major hemorrhage situation is not something that could be done by 1 or 2 people well, and is much better done by a team of people. We should use the blood products that are in our fridges, and you should know what's in your fridge. That is our theatre fridge at St Mary's, and it contains 8 units of O positive, 4 units of O negative, 4 units of pre-thawed FFP, and some fibrinogen concentrate. And there are guidance on usage times and how long it can be safely out of the fridge or before it needs to be returned. Much of modern major hemorrhage management comes from damage control resuscitation, and this comes from the trauma setting and consists of 3 elements: damage control surgery, hemostatic resuscitation, and permissive hypotension. I'm not going to talk about the 2 in blue. I'm going to talk a bit about hemostatic resuscitation, and we can see how we can apply it to other areas beyond the trauma setting. So hemostatic resuscitation aims to avoid the well-known trauma triad of death, of acidosis, hypothermia, and coagulopathy. But more recently, this triad has been updated to a diamond, including hypocalcemia. And it's important that we keep on top of the calcium during management of major hemorrhage. With any injury, trauma particularly, but also obstetrics leading to hemorrhage, you get shock. And part of that resuscitation, as well as other medical diseases, if you start resuscitating with crystalloid fluids, for example, at least the dilution, the patients become cold, they become acidotic because of the shock, and it all leads to coagulopathy. And the principles of hemostatic resuscitation is to try and prevent this. So it's a rapid and effective restoration of blood volume, and also to maintain the functional blood composition so that the patient clots, they've got oxygen carrying capacity, they've got oncotic pressure, and that the biochemistry is maintained. So as an overview, the main principles are to avoid, or as far as possible, or limit crystalloid, follow a major hemorrhage protocol, and regularly, and as an organization or system, we need to be looking at how well we do that and auditing it regularly. The initial response should be a balanced transfusion of 1-to-1-to-1 therapy, and then latterly guided by point of care testing, so arterial blood gases and viscoelastic assays. And that point of care guided transfusion should include tranexamic acid. I've got the details there for trauma, but I'll come on to a bit more detail of tranexamic acid in a moment. Calcium chloride of 10 millimoles per resuscitation pack. So typically in the UK, blood will be delivered in a major hemorrhage setting in a 4 red 4 FFP package, and per 4 red cells you need to be thinking about giving 10 millimoles of calcium chloride. Could also be giving a bicarbonate infusion and keeping an eye on the arterial blood gases, and thinking about insulin dextrose. If there is reversible anticoagulation in the patient, then we can reverse it, and we should be thinking about using cell salvage for all instances where this is appropriate. Where did the 1-to-1-to-1 therapy come from? Well, it is the empirical optimal transfusion platelets of red cells to FFP to platelets. Now remember, platelets are pooled, so you get 5 units in one bag. So 4 red cells, 4 FFP, and 1 bag of platelets gives you roughly 1:1:1 ratio. And this little table here on the right shows, you can see down at the bottom right, that the patients who had the intervention of 1:1:1 were more likely to achieve hemostasis and less likely to die by exsanguination within 24 hours, although notably that is in the post hoc analysis, not in the primary or secondary outcomes. There's all sorts of guidance and variety of major hemorrhage protocols out there. No doubt you'll have your own. This is ours, but there are these should be followed. One principle of hemostatic resuscitation is that all administered fluids should either carry oxygen or clot. When blood is taken from a patient, whole blood, 500 mils, has this composition, but it is then has some anticoagulant added, and it's spun down and split into various different constituents, because this provides the most benefit for most patients by the blood service. But what you have to realize then is that 1:1:1 therapy, even though this is the gold standard, doesn't give you what's been taken out of a healthy patient. It gives you blood with a lower hematocrit, less platelets, and less coagulation activity. And the physiology, this is not, or the biochemistry of that bag of blood isn't normal. So this is an arterial blood gas taken from a bag of red cells, and you can see that although the hemoglobin is very high, the calcium is non-existent and the potassium is very high. So if you're giving large volumes of it, that is why we need to monitor the arterial blood gas and venous blood gas regularly, because what we are giving is not as good as what the patient is losing. And I alluded to it earlier, you need to call for help. Management of major hemorrhage is a team support. So there should be one person coordinating on the anaesthetic side, and they should assign roles. So a blood monitor or blood bank liaison, somebody to manage the rapid infuser, and somebody to manage cell salvage. And that blood monitor needs to know what has been given, and they need to keep a tally, what is available in the room to give, and what has been requested from the blood lab, because there may be a delay in getting blood from the lab. Where possible, blood should be requested in advance, and you should be anticipating what the ongoing blood loss is like. And that's why it's drapes down surgery, so that you can see the surgeon. You can see in this bottom picture the drapes are not up, and the anaesthetist has got his arm up hanging over the rapid infuser, but he's actively watching the surgery and also on the phone to the blood bank, so he can see what the blood loss is and be that critical point of communication liaison. And as part of those human factors, we need to talk to our surgeons, and there's a couple of ways a couple of things you need to talk about. The top Snapchat and the bottom based is from St Mary's in the Royal London. These are just aid memoirs to trigger conversations. We recommend that they're held every 15 to 20 minutes. So surgical process, how are they getting on? How much blood's been given? What do the point of care testing results look like? What's the plan? What do the electrolytes look like? Are things getting better, or are they getting worse? These are the sort of things that need to be spoken about every so often during management of major hemorrhage. Tranexamic acid is a synthetic lysine derivative. It reduces thrombus breakdown. There's a variety of different indications. It's generally very safe, but the dosages differ depending on the cause of the bleeding. It's not recommended in GI bleeding, but it is for almost all other types of hemorrhage, and the doses are there. The other things to do, practical elements, we should warm the patients, targeting a temperature above 36 degrees centigrade. We should monitor it. Anything going into the patient should be warmed. It should be warmed under and over, and any exposed areas should be covered, and the breathing circuit should be humidified. And this will help keep the patient warm, or at least stop them losing heat. And we should be reversing anticoagulants and correcting hyperkalemia where it exists. And there's a regimen there for managing it. In terms of monitoring and targets, we need to monitor the ABG and TEG every 15 to 30 minutes and look at the rate of ongoing blood loss and surgical progress. And there's some targets suggested on the right. So during acute major hemorrhage, the hemoglobin is unreliable, but we should be aiming roughly for 70 to 90 grams per litre, platelets above 50, aiming to normalise the TEG with a functional fibrinogen above 2. And from an ABG blood gas perspective, we should be aiming for pH above 7.3 and looking for improving trends in the basic excess and lactate and maintaining calcium level above 1.2. That is my very brief whistle-stop tour through major hemorrhage. Thank you very much for listening and for having me on to talk. There's a little summary slide here from Anaesthesia in 2023, which outlines everything that you need to do in a one-stop infographic in the management of major hemorrhage. Thank you very much.